السلام عليكم ورحمة الله. طلبتنا الأعزاء, today we'll discuss the renal parenchymal neoplasm. As you know, the neoplasm is divided into benign and malignant tumor. So we'll divide the renal parenchymal tumor according to that to papillary adenoma, oncocytoma, and angiomyolipoma. This is the benign tumor that involves the renal parenchyma. So we'll start with the first one, which is the renal adenoma. Most renal adenoma is incidentally finding. What we mean by incidentally finding, it is found when we do investigation for other component of the patient. So it's send patient for investigation by ultrasound or by CT scan. Appear there is a lesion in the kidney, and this lesion in form of renal adenoma. Most common benign renal parenchymal lesion. These are small, well-differentiated glandular tumor of renal cortex. They are usually asymptomatic and discovered incidentally, as I said. No clinical, histological, or immunohistochemical criteria differentiate adenoma from carcinoma. It is very important. So there is no way for differentiate it clinically or histologically or immunohistochemical criteria, special criteria for adenoma. But when we do removal of it by removal of the tumor and then send for histopathology, in histopathology we can differentiate it. Renal tumors less than 3 cm usually were considered adenoma till proved otherwise and had little propensity of metastasis. Okay, this is the special criteria for renal adenoma. Some consider it incidentaloma, renal tumor. Okay. The other one, benign renal parenchymal tumor, it is the oncocytoma. Has a spectrum of behavior ranging from benign to malignant, composed of large epithelial cell with eosinophilic cytoplasm, oncocyte cell. Patient may present with a gross hematuria or flank pain, occur less than 20% of patients. No characteristic feature of the tumor appear on CT scan, ultrasound, IVU, or even the MRI. Angiographic feature include spook wheel appearance of the arterioles. The third one, it is the angiomyolipoma, AML, angiomyolipoma, or renal hematoma. They are characterized by 3 histological components: fat cell, smooth muscle, and blood vessel. This criteria very important for diagnosis and identification of the AML, angiomyolipoma. So we can identify it by CT scan. CT scan show renal mass, but with the special criteria. It is fat cell, contain fat. So the density of on CT different from renal RCC or renal cell carcinoma. Usually about 45 to 80% of angiomyolipoma associated with the tuberous sclerosis. It is a type of congenital anomaly. Patient with a tuberous sclerosis have angiomyolipoma. Negative density minus 20 to minus 80, minus 20 to minus 80 ounce per unit NCT pathognomonic of angiomyolipoma. Treatment depends on size. Patient have tuberous sclerosis or no, and size of lesion by CT scan, 4 cm more or less. But in our mind, patient with angiomyolipoma, when it is large size, especially in female and in a pregnant female and pregnant lady, there is a spontaneous rupture of angiomyolipoma. So a patient is presented with bleeding like hematuria or retroperitoneal hematoma. In this case, it is considered a life-threatening case. It is one of the emergency condition. Criteria: patient with renal mass, pregnant lady, sudden onset of hematuria or retroperitoneal hematoma. Sometimes come with shock state. So it's considered Wunderlach syndrome. Wunderlach syndrome. And patient need urgent nephrectomy. Other rare tumor like leiomyoma, hemangioma, renal lipoma, and juxtaglomerular cell tumor. Juxtaglomerular cell tumor, as known, it is renin secreting cell present in the renal tubules. So this secretes more renin, as the renin have an renin angiotensin aldosterone system. It is a part of this system. So when there is increased secretion of renin and proportionated to the body need of this secretion, it will cause hypertension. So it causes renin, angiotensin, aldosterone system activation of this pathway. Now we'll go for malignant renal or renal parenchymal tumor. That is the adenocarcinoma of the kidney or renal cell carcinoma, clear cell carcinoma or renal cell carcinoma or adenocarcinoma of the kidney. Most common in the 5th to 6th decade, male-female ratio 2:1. The cause of RCC remain unknown. It originates from the proximal convoluted tubule of the cortex and tend to grow out into the perinephric tissue. Histologically, most often mixed adenocarcinoma containing clear cell, granular cells, and occasionally sarcomatoid appearing cells. RCC are a vascular tumor. RCC are a vascular tumor. Spread. Direct invasion through the renal capsule. Direct extension into the renal vein. 25 to 30% of patients have evidence of metastatic disease at presentation. Risk factor: smoking, occupational, genetic, acquired renal cell disease. Renal cystic disease. This is the TNM staging, the grading and staging of the RCC. The ultimate goal of staging is to select appropriate therapy and obtain prognostic information. So, stage 1, tumor is confined within the renal parenchyma. Stage 2, tumor is confined within the geroid fascia, including perinephric fat and adrenals. Stage 3A, tumor involve main renal vein or IVC. 3B, tumor involving regional lymph node. 3C, tumor involve both local vessel and regional lymph node. Stage 4A, tumor involve adjacent extradural organs, colon, pancreas, and etc. Stage 4, distal metastasis. Grading system are 4 grades, from well-differentiated to undifferentiated. Symptoms and sign. The classical triad of gross hematuria, flank pain, palpable mass occur in 7 to 10% of patients, and frequently manifestation of advanced disease. 2 to 16% of patients present with the growth of microscopic hematuria. Pain, abdominal mass, or both. Abdominal mass or both occur in 40% of patients. Symptoms secondary to metastasis, dyspnea, cough, seizure, headache, or bone pain. Renal tumor increasingly discovered incidentally due to the use of CT scan more than 50%. So the triad for presentation of patients with a renal mass, it is 3 criteria: pain, hematuria, and mass, and bubble mass, and with different percent for between patients. Some patients are presented with paraneoplastic syndrome, very important. Some patients present with paraneoplastic syndrome. So, occur in 10 to 40% of patients with RCC. It includes erythrocytosis, increase the BCV, erythrocytosis, hypercalcemia, hypertension, and non-metastatic hepatic dysfunction. It does not include poor prognosis, usually relieved after nephrectomy. Okay, some symptom, patients come with a complaint. Said he has one of the paraneoplastic symptom. It occurs because the tumor cell secretes hormone to the to blood. So under the effect of this hormone, different changes and different complaint of the patient, all of it said or named as the paraneoplastic. So because increased secretion of erythropoietin come with erythrocytosis, or because of continuous loss of blood in form of microscopic hematuria, it will cause anemia. So patient may come with anemia or come with erythrocytosis. Both of them presentation of the RCC. Also, patient may come with hypercalcemia, or presented with hypertension or hepatic dysfunction. It said HELP syndrome, in form of HELP syndrome, hepatic dysfunction. Okay, all of these paraneoplastic not mean metastasis, so not mean a poor prognosis. And this paraneoplastic manifestation disappear after removal or after nephrectomy. Laboratory finding: 30% anemia or increase the ESR, and on imaging by ultrasound is highly accurate in distinguishing simple cyst from the solid lesion. من انجاز المريض investigation, as you know, the radiologist easily to differentiate between the solid tumor and the cystic lesion. Sometimes also we have cystic lesion or RCC come in form of cyst, but there is a special criteria for this cyst can differentiate by CT scan. Okay. Also, CT scan is more sensitive than ultrasound and the IVU or IVP. Show renal mass that enhance with contrast. CT is a method of staging. MRI to evaluate vascular invasion. So when we suspect there is an invasion of the renal vein or the inferior vena cava, there is importance for the use of the MRI. And geography also important to identify the vascular involvement, okay, and also the radionuclide imaging. Management mainly depend on the stage of a tumor. Localized radical nephrectomy when kidney, perirenal fat, and adrenal gland removed. Disseminated 30% of patients presented with metastasis, usually aggressive and rapid progressive. Palliative surgery, radiotherapy, hormonal therapy, and chemotherapy, plus biological response modifier like interferon and interleukin, and observation. Okay, so for treatment of the renal mass, treatment of the renal mass according to size of tumor, and according to patient well-being and the condition of the other kidney. So we should put in our mind very important point. If the size of the renal mass, if it is exophytic, I mean it is in the upper pool or the lower pool of the kidney and prominent from the renal cortex. So it appears like exophytic position and a size less than 4 cm. They previously said 4 cm. Now they said also may reach to 7 cm. But it is considered a candidate for partial nephrectomy. Partial nephrectomy will remove the tumor with safe margin, with 2 cm safe margin. Okay? Sometimes the patient borderline renal function, and sometimes there is suspicion of involvement of the other kidney. Sometimes patient have any condition that involve that need to do the partial nephrectomy. So nowadays in urology there is the use of the partial removal of the kidney. Okay. This depends on size and of the position of the tumor. The position of the tumor important because maybe a small size tumor less than 4 cm but located near the renal hilum. So in this condition we cannot remove the partial nephrectomy because of involvement or near the major branch of the renal artery. So gold standard of nephrectomy, radical nephrectomy, but sometimes there is need for do the partial nephrectomy. Okay. Nephroblastoma, Walm's tumor. Walm's tumor. نشوف شنو worms أو Wilms is a tumor. Most common solid renal tumor of childhood. Peak age for presentation is the 3rd year of life. There is no sex predilection. So it is male, female, equal. 10% have congenital malformation like an iridia and genitourinary abnormalities. Pathology. Tumor described lesion is nephrogenic rest. Typically consists of blastomal, epithelial, and stromal. Each of two types. Favorable contain no aneplasia, and unfavorable contain aneplasia. Okay? Nephroblastoma, a tumor of childhood. Peak of presentation, it is a 3rd year of life. And pathologically, we have two types of a tumor. Tumor precursor lesion is nephrogenic rest, typically consists of blastomal, epithelial, and stromal. It is of two types, favorable and anaplastic, and unfavorable, and containing aneplasia. Metastasis, direct hematogenous and lymphatic. Clinical finding, asymptomatic mass is the most common discovered by the family member or physician. البيبي يجيبوا أهله أو أمه تقول لك وأنا دا أغسله أو شيء أحس عنده فد ماس abdominal mass. هذا most common presentation. Abdominal pain, distension, nausea, vomiting, anorexia, and fever. The most common sign is abdominal mass and hematuria. Abdominal mass, hypertension, and hematuria. Laboratory, hematuria, and anemia. Imaging. Ultrasound is the current initial study of choice to evaluate palpable abdominal masses. CT scan, useful in providing tumor extension, state of contralateral kidney, and lymph node involvement. IVU to evaluate renal masses, but had been replaced by newer modality. Chest X-ray to evaluate the presence of lung metastasis. Needle biopsy indicated if tumor too large for resection, for which chemotherapy or radiotherapy is planned. So, if we have a large mass, sometimes we do needle biopsy. If it is a large mass and resectable, because there is a probability for use the chemotherapy and radiotherapy before we do nephrectomy. Before do nephrectomy, we go for chemotherapy and radiotherapy. Differential diagnosis: hydronephrosis, cystic kidney, and neuroblastoma. Treatment: surgical measure, radical nephrectomy, chemotherapy. Once the tumor is a chemosensitive, and radiotherapy, it is also radiosensitive. So 3 modalities for treatment of once a tumor. Okay, very important. And once a tumor, to see this 2 types. If it is favorable or unfavorable tumor. If favorable tumor, we can do nephrectomy directly. And if unfavorable tumor, we can give chemotherapy or plus minus radiotherapy, chemotherapy, plus minus radiotherapy, and then do nephrectomy. Okay? This is the lecture about the renal neoplasms. Thank you very much. And if you have comment or any question on this lecture, you can put it on the classroom. Thank you very much.